So we're going to talk about craniosynostosis, in neuro. And the way this comes to us is optic neuropathy, or increased intracranial pressure related to shunting procedures, shunt malfunction, dorsal midbrain syndrome, or the non-localizing six-nerve palsy. But the reason you need to know about it is vision loss occurs in patients with these craniosynostoses, and the mechanism is usually increased intracranial pressure. Now there's this alternative mechanism, which is optic canal stenosis. This is a diagnosis of exclusion. So first you need to make sure it's not ICP. Second, you need to make sure it's not some other cause of optic neuropathy, and then you can blame it on optic canal stenosis from the bone. So as you know, in a kid, there are sutures, and these sutures don't normally close until after you're done growing. And so the sutures make like a cross and then a lambda like this, the Greek letter, lambda. This is the metopic suture at the top here. Then you have a coronal suture, and then you have a sagittal suture, and then you have this lambda suture. So premature closure of these sutures is what we call craniosynostosis, and the most common is the Cruzon and the Apert syndrome. They're very similar. They're both autosomal dominant. They both result in bicoronal suture closure, and what that causes is it causes brachycephaly because the skull can't expand, so they get this kind of like pumpkin-looking skull. If you have premature closure of the metopic suture, you get a triangle head, trigonocephaly. And if you get a problem with the sagittal suture, then you get a boat-shaped head like this, which is scaphocephaly or dolichocephaly. And you can have combinations of these things that can lead to a cone type appearance, which is oxycephaly. So all of these different cephalies, trigonocephaly, brachycephaly, scaphocephaly, dolichocephaly, are manifestations of premature closure of these sutures, metopic, coronal, sagittal, and lambda. If you just get one side, either one coronal rather than bicoronal or one lambda, you get plagiocephaly. Plagio means only one side is affected. So in the Cruzon syndrome, they have a very characteristic appearance. They have mid-face hypoplasia. They have proptosis and strabismus. The eye is often turned out. And if you close your suture too early, your pressure will go up in your head, and that is increased intracranial pressure. We also have to worry about hydrocephalus and the Chiari malformation in the Cruzon's people. And they might have to have a ventriculoperitoneal shunt. So the way this comes to us in neuro-op as adults is a child with this craniosynostosis, the Cruzon, who has a shunt, presents with painless progressive loss of vision bilaterally, with or without papilledema. It can just be optic atrophy because the dead nerve can't swell anymore, so there's not going to be any more papilledema. You should really be checking the integrity of the shunt, scanning the person for hydrocephalus, looking for the Chiari malformation, and then a CT scan of the orbit is going to be performed if everything is negative to look at the canal. And that is primary optic neuropathy after Cruzon, caused by the canal stenosis, for which some people have advocated decompression of the canal, but I don't recommend this. So in the Cruzon and the Apert, they're very similar. They have the same autosomal dominant gene. It's the fibroblast growth receptor, and Apert has this extra thing, which is syndactyly. Apert patients often have cervical vertebrae abnormalities, fusion, and their intelligence is decreased. The Cruzon people, normal intelligence, no syndactyly, but it's the same gene. This on chromosome 10, this fibroblast growth receptor gene number 2. So you need to know a little bit about craniosynostosis, including Cruzon and Apert. The sutures close prematurely. It changes the skull. They get increased ICP, hydrocephalus, Chiari. They might have to have a shunt. And if they come to us as adult with vision loss and optic atrophy, you got to check the function of the shunt.